Welcome to today's webinar brought to you by GrassrootsHealth. Thank you everyone for attending. This week we welcome Dr. Bruce Hollis again, Ph.D. and professor at the Medical University of South Carolina, and co-author to several papers on vitamin D in human lactation, pregnancy, and infant health. We are very honored to have Dr. Hollis presenting his newest research on the subject of vitamin D in lactation, which he just recently, as in this past week, presented at the Pediatric Academic Society's annual meeting in Washington, D.C. Dr. Hollis, am I correct to assume that today's audience is the first public audience to hear this latest information?
Yes.
Awesome. I find that very exciting. And how long have you been doing research on vitamin D in pregnancy and breastfeeding?
Since about 1978. And this particular project that I'm presenting today was initiated in, I think, 2005. It took 6 years to do this. It was funded by the National Institutes of Health. It was very expensive to do and very personnel intensive.
Wow. Well, congratulations, and we're very excited that we can help you get this information out. And thank you so much for your time today, Dr. Hollis. With that, I'm going to give you the floor.
Thank you all for listening. The title is Results of the National Institutes of Child Health and Human Development two-site maternal vitamin D supplementation study in lactation. There were 2 sites on this, one of them here at the Medical University of South Carolina, and another site was in University of Rochester, New York. We wanted to have a north site and a south site, and also this type of clinical trial where you're dealing with women who are lactating over a 6-month period is very difficult to do. What you're looking for when you do this trial is women who are dedicated to lactating. One of the things that we learned is right after birth, if you walked in and you asked a woman, do you want to be in this trial? Are you going to breastfeed? And a lot of them would say yes, and they wouldn't realize what they were in for with the breastfeeding, and they wouldn't last a month, and dropout rates were enormously high in the initial study. So with this study, the enrolled criteria is they had to be breastfeeding solely for that first month following birth, and it made for a lot better study. But these kind of patients are extremely hard to enroll in studies. Next slide. Again, I come back to the Institute of Medicine recommendations, and basically they say one amount fits all, and that never made a whole lot of sense to me. That a child, newborn baby here on the left side of this slide, could have the same vitamin D requirements as Governor Schwarzenegger here in his prime. So, and they don't. It doesn't make any sense, but basically it's a simplistic way of looking at this, and it certainly doesn't apply to pregnant and lactating women. Next slide. It's a well-known fact that human milk is a poor source of vitamin D for the nursing infant. I remember in the mid-70s when I was in college and being in nutrition classes, we were told that human milk was the ideal food for the newborn infant, except if they would consume it, they would get rickets. And I thought, how on earth could that have happened? How could human milk, the sole source of milk, cause an infant taking it to not develop bones and get rickets? Next slide. It's an absolutely false and absurd statement, and it goes back again to the requirements that are put on again, Institute of Medicine saying that a lactating woman only needs to have 400 international units of vitamin D per day. Well, under those conditions, human milk is inadequate for their nursing infant. So they're trying to fit the requirements to the not have the requirements fit for the physiologic state. And it's been known for a long time, in the last 100 years, that if children who were breastfed and not given supplemental vitamin D were subject to rickets. You can look at this slide and see cases of rickets in London in 1889, and even now it still exists. And they're sad tales. Next slide. The problem with the vitamin D, as you've heard in a lot of these talks, is vitamin D essentially does not occur in natural foodstuffs. So unless you eat a lot of wild salmon or drink cod liver oil, which isn't advisable, you're not going to get much vitamin D. Next slide. Now, we didn't used to be like this. Up until 50,000 years ago or so, we were all dark-skinned like this chap on the right side. We ran around sub-Saharan Africa. We didn't wear clothes. We were in sun all the time. There was really no season. We had unlimited sunlight. That's the reason for the black skin, because under those conditions you would be incredibly burned. But this allowed for unlimited sun exposure and limited vitamin D production without being burned with the light skin. The problem is when individuals left sub-Saharan Africa, say 50,000 years ago, and mostly migrated north, the sun intensity greatly decreased until they got to places like northern Europe. And what happened there is we all turned into what Jane Goodall looks like. We lost our pigmentation. Now we know how this happened. We know which gene was involved in the mutation, and by tracking that gene, this has been published in Science magazine back in 2005 to 2007. We know that this pigmentation loss happened about 10 to 12,000 years ago, and it happened when humans stopped being carnivores and hunting their food and eating sources of meat, and to be primarily becoming farmers and eating plants. And when that happened, and the lack of sunlight, we lost our pigmentation to conserve the amount of sunlight you would get in those northern latitudes. Had that not happened, birth probably wouldn't have happened, because it's tough for a woman to give birth in a rachitic pelvis to a child when both would not survive that event. Next slide. And to go back, how much vitamin D, up until not long ago, the only way we got vitamin D pretty much was by the sun, because we didn't know that it existed. And that's only been about the last 100 years when vitamin D was discovered and synthesized, and you can take it in a pill. Before that, they really didn't know what it was or what happened, but it didn't matter, because we all got plenty of vitamin D through sun exposure. And how much vitamin D is that? Well, they measure doses of UV irradiation sunlight by minimal erythemal dose, and that in easy terms, that would be sitting outside in the direct sunlight for about 20 minutes of total body exposure. And if you're a Caucasian and you do that, you're going to make about 20,000 units of vitamin D, and it'll be released into your circulation within 24 hours. If you go back to the slide and remember the chap I showed you on sub-Saharan Africa, well, he can make the same amount of vitamin D that a light-skinned person can make, except he needs 10 times the exposure to make it. Now, that doesn't matter, and it's his advantage to have that kind of exposure when you're in the sun all the time in Africa, sub-Sahara. But it doesn't really cut it very well when those type of individuals come north, where you have dramatically reduced sunlight exposure. You just can't spend enough time. So people of color are the most affected by this. And interestingly enough, the highest rates of rickets in breastfed babies are by far from dark-skinned individuals. And I've seen this, I've witnessed this, I've heard people give testimony of African Americans who mothers want to breastfeed, and they breastfeed, and for some reason they're never told by their pediatrician to either give their infant, which is a recommendation by the American Academy of Pediatrics, that each newborn infant breastfeeding would get 400 units of vitamin D per day by drops. Nobody recommends that the mother take it like I'm going to do in this talk, but that's the alternative that we've come up with, and the natural way, because again, how could you solve this problem 100 years ago if you didn't even know it existed, and how would you give the drop? So that's a panacea. It's not a remedy. Next slide. The reason that we got into this predicament, I'm sure you've heard this 1,000 times and other people talking on Grassroots, it was because back in 1997 they set an arbitrary level of safety for vitamin D at 2,000 units per day. Now, remember back to the previous slide when you could make 20,000 units from the sun, and nobody considers that harmful, but they consider 2,000 units by mouth to be harmful, and that was an absolutely ridiculous statement. It really harmed vitamin D research for decades. The new level set by the Institute of Medicine is arbitrarily, as far as I'm concerned, arbitrarily set at 4,000 units a day, which is better than 2,000. But I don't know where that number came from, except that we had obtained an investigational drug application from the FDA to do studies such as this back in 2003, and they approved us to do 4,000 unit studies, which we've done, and never had a single adverse event. In fact, of all the studies that I've looked at, not just my own, but many others, on levels up to 10,000 units intake a day, I've yet to see, or higher, I've yet to see an adverse event dedicated to the intake of vitamin D, although, you know, a lot of my colleagues say it's still there and they keep looking. But I think they're looking for something that doesn't exist. Next slide. Just to give you insight into this, I mean, again, the Institute of Medicine panel, and so for years we've done studies since the mid-'80s about breast milk and what vitamin D compounds are in breast milk and how do they get there and which ones are there. It turns out that the form of vitamin D that is in breast milk is the parent compound, vitamin D itself. It's not, that's the one that's transferred into the milk. 25-hydroxy vitamin D does not readily go into milk. So you can't look at a woman's 25-hydroxy vitamin D level and think her breast milk is going to be okay because it doesn't get in. Now, Dr. Kovacs here was on the IOM panel, and he made this statement in a recent article that he published here, that breastfed infants are at especially high risk of vitamin D deficiency due to poor penetrance of vitamin D metabolites in the milk, which is technically true. But what they haven't been following for the last 25 years is what I've said. It's not the metabolites that go into milk, it's vitamin D that goes into the milk. Now, his statement's also based on the assumption of a 400 international unit intake of maternal vitamin D requirements. Well, when a woman takes 400 units of vitamin D today, guess how much vitamin D, the parent compound of vitamin D, is in her milk or in her blood? Nothing. There's nothing there. And so if there's nothing in her blood, she can't transfer any compound into her milk, and of course then her infant's vitamin D deficient and her milk's deficient. It's that simple. And it just astounds me that over the years, these people on these committees simply don't understand the literature that's been placed in front of them. Next slide. Now, this was an interesting case. This goes back again to, this is a paper that was done in 1985. And I looked at this paper in ways different than my collaborators did. Frank Greer, who now sits on a lot of these panels, who's at Wisconsin, he and I don't see eye to eye on this, but the data that are here, and basically what this patient, one day he got this patient, he's an endocrinologist, sent it over. This lady, in this, you could go look at the paper, it's published in 1985. This lady had hypoparathyroidism, which means she couldn't maintain her serum calcium. So in those days, the way that serum calcium in the mother was, or anybody was maintained, was that they were given 100,000 units of vitamin D per day. Now that maintained her serum calcium. Now this individual got pregnant not once but on 2 separate occasions and delivered 2 normal children. Okay, so a couple of things here. At the time, vitamin D was thought to be a teratogen, meaning if you took too much, your baby could have 3 different arms and 2 heads and a lot of mutations. Well, twice she gave birth to a normal child, and her blood levels, if you look at this slide, were huge. The maternal levels of vitamin D were 500 normally, and a normal person who's not taking any vitamin D, there's nothing. And then the 25-hydroxy levels, if you look at the top, 545 nanograms per ml. Now the interesting part, if you look down at we not only measured it in her blood, we also measured it in her breast milk. And she was very interesting because most of the time we were messing around with breast milk that had, at this period of time, that had levels so low that our methods could barely detect anything because there was just not enough there. This lady had huge amounts. Her breast milk had 155 nanograms of vitamin D2. Look at the ratio between the vitamin D2 in her blood, 551, in her milk, 155. And don't pay attention to the D3 because she wasn't taking any. But look at the 25 D2 in the serum, 545. Look at her milk, 7.3. It doesn't go in. All of activity in her milk is from the vitamin D primarily. And how much activity did this woman have in her milk? If you look to the far right, international units per liter, almost 8,000 IUs per liter. Now this is pharmacology. But we subsequently did studies on normal women, and what we came up with is that for every 1,000 IUs of vitamin D intake by the lactating woman, she could provide about 80 IUs into her milk for a nursing infant. So what that means is this woman was taking 100,000 units. She had 8,000 units per liter. Of course, no one wants to do that. But what it means is if a woman took 10,000 units a day, she could put in about 800 units per liter into her milk, and that absolutely would satisfy the requirement for her infant. And this, even though this was in a woman who had very high, the same ratio holds all the way down through the physiologic concentrations. And I can't go through all the data, but we had done that. Next slide, please. So we went to NIH back in 2003, and we were asking them for several $1 million to do this study. And it's very difficult to get these type of grants. Today, I would virtually say in this day and age, right now, it would be totally impossible to do this because they simply don't have the money to do it, but they did then, and we got this grant. But one of the things we had to do to get this grant was we had to do, this is a pilot study that got us the big grant, and it was run here in Charleston, and it was an interventional study, and what we did was we took 2 groups of patients. This is a maternal, the first group of mothers were given what we call standard of care, and that's this slide. Standard of care, and even today, standard of care, according to the American Academy of Pediatrics, is the mother would get 400 IUs of vitamin D for herself, and then her infant would be supplemented by drops by mouth, 300 to 400 international units per day. Now that's an ideal situation, but I can tell you that when mothers supplement infants with these drops, the babies don't like them, they spit them out, the mother looks at it and says, I'm not doing this anymore, and they discontinue it because the child looks okay, but the child is, if you discontinue it, will become progressively more vitamin D deficient if the infant is only taking milk from that mother as a sole source. So look at this graph here. This is visit by months. V0 is initial entry, and then visit 6. These are 1-month visits. It was done through the winter and into the spring. The vitamin D levels there, 2.4, 2.8, 3.5. Those levels are barely at the detectable level of the assay. Now there was some move up here at the end. And what that is these women in Charleston in the spring, we told them not to go in the sun, but they went anyways, and that was a jump in these levels. so they didn't follow directions. You look at the 25-hydroxy level in these women, they were good. If you looked at these women and you thought there's no problem here, they would have plenty of vitamin D in their blood, and you assume that it would be in the milk. And then the baby, by 300 units per day direct by drops into their mouth, their 25-hydroxy levels rose from 13 to 33 to 43 nanograms. That's quite good. But we also measured the vitamin D activity in the milk of these women, and this is standard of what you'd observe. This is why people would say breast milk wasn't adequate, because this is per liter, 62, 71 IUs per liter. They need 300 to 400, and they're not getting it from milk, even from these mothers. Next slide. So what we did is we had a treatment group. We gave the mothers 6,400 units of vitamin D per day, and the infants got placebo, meaning they just got what was coming through the mother's milk. So when we gave this mother 6,400 units of vitamin D, visit zero, her vitamin D levels were basically baseline. They instantly increased by a magnitude from 4 to 30 to 40 to nearly 50 nanograms per ml in her blood. 25-hydroxy D levels, as I mentioned, at this intake, everybody was afraid that the mothers would become vitamin D toxic and they would be hurt. No such thing happened. Their levels went up a little bit from 36 into the 50s. That's a good rise. The most amazing thing are these last two, infants. Nursing from these mothers, levels increased to 36 and 46 simply by this last line, getting the vitamin D, the mother's sending it into her milk, and the infant is taking it in their diet and increasing their vitamin D status. Remarkable study. It got us the grant, and we were in for a lot of work. Next slide, please. The objectives of our NIH study that we presented at the Pediatric Society was to assess the safety and effectiveness of maternal vitamin D supplementation at 6,400 units, and we also added in a 2,400 unit to mothers only dose and compared it to the standard maternal and infant dose of 400 units per day. Now, the 2,400 unit dose was put in there by the National Institutes of Health. We didn't want to do it. They said, yeah, we want you to do it, because that at the time was the upper safe intake, and they wanted to know if that would work. I said it won't. You can do the mathematical calculations, and you know that you're going to have a lot of failures. And they said, we want it anyways. I said, it's your money, we'll do it. So for 2 years, we ran this trial like this. And what was happening was we had a data and safety monitoring board. And the safety point of it was that the nursing infants had to maintain circulating 25D levels of at least 20 nanograms. If at any point in their visits they weren't maintaining 20 nanograms, they were then pulled and put on open label, which means they started directly getting vitamin D supplement by mouth. So after a couple of years, we're looking at the failure rates, and there are quite a few failures. And I asked the Data and Safety Monitoring Board to investigate it to see if it was concentrated in any specific group, which would have been 6,400 to the mothers, 2,400 to the mothers, or 400 to the mothers and 400 to the infants. And it was almost all concentrated in that 2,400 group, which means the mothers were taking it. It wasn't enough to go into their milk to supply the infants. And so we petitioned the NIH to stop that arm because it was a failure, and we went from there. The hypothesis was that breastfed infants 25 through maternal supplementation would be equivalent to the infant getting 400 a day with no differences in safety, would be superior to maternal vitamin D supplement with 2,400, which it was. Again, 2,400 was discontinued and didn't work because it just didn't maintain infant circulating levels. Next slide, please. So we started off with 476 mother-infant pairs. They were randomized to 400 each, which is standard of care. 2,400 some mothers only, and 6,400, and you can see that we only went as far as 71 and before the study was stopped because there was a 35% failure rate in that group of infants to maintain 25D levels. And in the other two groups, there was like a 4 or 5%, and that has to do with patient compliance. So as it says here, 2400 group was stopped in 2009 as treatment failed to increase levels and 5 and 6% versus 31%. So that was grounds to stop that part. It proved that the 2,000 units in this case is not only toxic, it's not only it's not toxic, it's not adequate for what you're trying to do. Next slide. And this is a flow diagram, a more comprehensive. You can appreciate here the complexity of this. And in fact, I can tell you that when you submit grants like this to the NIH, it's a long process. It goes through study sections. The study sections come back. One of the comments was, do you really think you could do this? This is a really intense clinical study that's going to involve a lot of people, and especially with women who are lactating, and trying to keep them in line and figure out what they're doing and make sure they're not cross-feeding. With bottle cross-feeding, it would be a violation of the study if the woman were breastfeeding and giving bottles on the side. That would violate and so you have to keep track of all these things. And I remember, you know, you always say to the NIH study section, oh yeah, we can do this, we can do this. And then when I got the grant, I turned to the study people and I said, can we really do this? And it took a year longer than we wanted to, than we took, but we finally finished the study. Next slide. So the results, maternal vitamin D status at baseline differed by, we did racial groups here. We did Caucasians, African Americans, Hispanic, which adds to the complexity of the grant, but you need to look at all these things by race and latitude. So maternal vitamin D status at baseline differed by race and ethnicity, education, and latitude, but not by treatment group. Okay. So the women, Caucasians had more vitamin D than African Americans, who had less than Hispanics, and the women in Charleston had higher vitamin D levels than the women in Rochester because they're farther north, things that you would expect to be. By 2 months treatment, trial sustained for 7-month postpartum. The treatment groups were already significantly different, meaning that our treatments were already raising 25D levels between the groups. There was no differences in infant 20, and this is really the key to the whole grant, number 3. There were no differences in infant 25 by treatment, okay, meaning that the levels were in the mid-40s, regardless if they got 400 units directly by mouth, as the AAP, American Academy of Pediatrics, now recommends, or we gave the mothers the 6,400 units and the baby got it through the milk. Now, I'm not a, you know, my wife has had children. We've done this. To me, it would be a lot more advisable for the woman to take it instead of struggling to put the drops in the infant's mouth. And the woman, the lactating mother, gets the benefits of having enough vitamin D. And 4 was always always the same thing. There were no adverse events related to treatment. This happens every single time one of these trials is done. No adverse events related to treatment. And I don't care which randomized controlled trial we've been looking at, whether it's pregnancy, lactation, bone studies for others. You know, they keep looking, the naysayers keep looking for these adverse events that simply do not exist. Next slide.
Dr. Hollis, I'm going to interrupt you just briefly. It is 10:30 right now. It's our 30-minute mark, and we do, just to honor everybody's time, we do like to thank everybody for being here. We are going to continue with the presentation as well as with our questions. We have lots of questions to answer. But quickly, I'm going to go.
Let me go through these quick, and I'll get to the last ones that are. Let me see the next slide.
All right.
These are the results of the study. So I'll quickly go through these. These were the different visits by this was grouped. These were all races together. maternal on top, infant on the bottom. These were the blood levels in the mothers when they entered, and then these are the mothers that got 400 right here, the light blue. These mothers got 2,400, and that ended, and these mothers got 6,400, and they rose nicely. Okay, and again, no adverse events. These were their infants. These infants right here, the light blue, didn't get any vitamin D through the milk. They got it through supplementation. And this is an ideal world where the mothers gave it to the babies and didn't stop. Here was the mothers. These mothers got, these were the infants from the mother, had 2,400 units. They responded, but not in a fashion that was adequate for all infants, and so it was discontinued. And the last dark blue ones here were the infants from the mothers who got 6,400. And the difference here is these two are the same, meaning that either one of these methods of supplying vitamin D to your infant is adequate. Again, I would think that putting it through the mother's milk, that's how it had to be done prior than 100 years ago when we didn't know vitamin D existed and we had drops. So that was a natural way. Next slide. And this is the same thing with only the 400 and 6,400 units broken down by ethnic group. And I just want to show you, this is really appalling. Now, this is an infant. They had been breastfeeding here for 1 month before we intervened. This is what the blood levels of a nursing infant look like in breastfeeding women. African Americans the worst because they have the lowest vitamin D. This is incredible, and this is why these infants tend to get rickets. And when you supplement them, the levels rise. African Americans, Hispanics, Caucasians. So the initial levels, you can see the racial differences. Here's the infant levels by African Americans, extremely low. Hispanics, not quite as bad. And Caucasians are nothing to write home about. They're down there too. I mean, this is below 20 nanograms. Some of these were probably 5 or 3. I mean, it's in Rickets territory. This is the problem. Next slide. So the conclusions, mothers taking the currently recommended 400 units of vitamin D will not be able to provide adequate vitamin D into their milk for their nursing infant to achieve adequate vitamin D status in that infant. Women need at least 6,000 units a day to ensure that their nursing infant receives adequate vitamin D, and this would avoid the need for direct infant supplementation. Infant intakes up to 10,000 units and circulating levels up to 100 nanograms are normal in human physiology. They shouldn't be treated as poison. Design of vitamin D dosing regimes for clinical trials are based on normal physiology and not for convenience and compliance. And by that, what I mean is, when you design a study in this particular study, it has to be a daily dose. It can't be once a week. It can't be, ideally, it doesn't want to be once a month, because vitamin D itself goes away really fast. That's why it gets into the milk, and it needs to be put there the mother needs to take that supplement every day. So it's not something that could be set up. Oftentimes vitamin D studies are set up where they're given once a week or once a month or once every 3 or 4 months. Can't do that here, and I believe you can't do it in a lot of trials. So anyway, that's a presentation, and I'll accept any questions that you have.
Great. Thank you so much again, Dr. Hollis. And we certainly have a lot of questions. Before we move on to the questions, just a couple announcements for those of you who do need to leave. If you look on the Grassroots Health website, we do have this brand new FAQs for vitamin D for pregnancy and breastfeeding. It's on our documentations page. You can find it at this direct link up here. But a great resource to have. And then for next week's webinar, we have a very special opportunity. Our director, Carol Baggerly, will be up in Oregon at the Linus Pauling Institute's Diet and Optimum Health Conference, where Thursday's schedule is all about vitamin D, and she will be interviewing the presenters from Thursday with your questions. So if you have any desire to ask those presenters any questions about vitamin D, please be sure to register for next week's webinar by tomorrow and get those questions in so that she can ask them on Thursday. So starting with our questions, we have a lot of questions about levels and dosage, and I know that you probably covered a little bit of this. So if you find yourself repeating information, we can briefly address any unanswered portions of these questions, but I'll go ahead and start asking. So question 1, is it best to supplement the infant with vitamin D drops, or will they get enough from the mom through breast milk? And I believe you answered that.
Yeah, yeah. I mean, the mother needs to take between, 6,000. I mean, even 10,000. The woman takes 10,000 units a day. I've not seen any evidence that that's going to hurt her, and that'll supply about 800 units per liter into her milk for her nursing infant, which is, quite a good amount.
Okay, great. Number 2, what supplementation dose should we recommend to breastfeeding mothers in general who do not know their vitamin D status? And at what point does the baby get enough vitamin D from the breast milk? My doctor says 400 IU per day, but I read it should be more, and I think you already addressed that as well.
I mean, from our instance with our studies here, 400 I mean, there's been a few papers on this published recently. In our work, I mean, 400 units per day to an infant would be about 4,000 units to a good-sized adult. You'd get the same response. So I think 400 units does, but having more, 600 or 800 units certainly wouldn't hurt. So, and again, it would depend for your child as how big it is, how much milk is it drinking, but I mean, if I was a mother, I wouldn't even consider giving that child drops. As long as I was breastfeeding, I would take it every day and let the infant get it through my milk.
Right. Okay, question 3. My prenatal vitamins only have 600 vitamin D3, and I will be giving birth soon. Should I start with 200 or more, and this is during pregnancy?
I would start taking 6,000 units right now.
While still pregnant.
Yeah. I mean, we did a study, I can tell you, we did a study with 4,000. So you could take 4,000 units up until you deliver, and then you would up it to 6,000 units for lactation.
Okay. And the
prenatal vitamins are pretty useless. 600 units really doesn't do much of anything for anybody. I mean,
right.
It would for your child, it doesn't for you.
Right. And that actually addressed parts of question 4. So should I start supplementing with higher doses of vitamin D while still pregnant? And you just said yes. How long does it take for vitamin D to build up in my breast milk? And then the last piece.
You take a dose, and it's in your blood. An oral dose will appear in your blood starting in about 2 hours, as soon as absorption from the intestine starts, and it instantly goes into your milk. And it will instantly disappear from your milk because that's why you need to take it every day.
Right. And then just if you wouldn't mind addressing the safety issue of vitamin D during pregnancy, is it safe to take while pregnant?
Oh, yeah. I mean, it's to your advantage to take it. You should be taking it before you're even thinking about getting pregnant. So people ask me that. I mean, our studies, we couldn't start looking at the pregnancy until 12 weeks when they would come in to find out if they were pregnant, but the truth is that you would want to be on the vitamin D supplement before you ever got pregnant.
Okay, great. And we did actually do a webinar on vitamin D during pregnancy. For those of you who would like specific information on that specific topic, you can find a recording of that webinar on our videos page. Question 5, shouldn't pregnant and lactating women dose vitamin D the same as everyone by maintaining 50 to 70 nanograms per milliliter in the blood due to different individual absorption?
From again, when you're looking at mother's levels in lactation, 25D levels aren't telling you very much. Okay, You could have great 25D levels, but if you didn't take your vitamin D for a week, you'll have zero vitamin D there. So the amount of 25, you're not going to have much. 25D doesn't go into the milk. It's vitamin D that goes in. And so the predictor in lactation is, did I take my vitamin D supplement today?
Okay, I'm gonna go ahead and skip forward then to question 8. Are there differences in the effect of vitamin D on mothers or infants based on the source of vitamin D? So if somebody's relying on the sun versus supplements, does that vitamin D still get into the breast milk?
Actually, back in the mid-'80s, we did those studies by taking women who were lactating and giving them UVB and measuring it, and yes, it does.
Okay, great. Question 6. Is it better to give high dose of vitamin D 1 to 2 times a week versus lesser doses daily?
For a lactating woman, you can't do that. You'll have erratic amounts of vitamin D in your milk. If you're giving it directly to the infant, yeah, you can do that.
Okay, but for the instance of breastfeeding, if the mother is taking the supplemental dose, it needs to be every day for that vitamin D to get in. Okay,
that's
great.
Right. Well, it needs to be every day because that's what it takes for her to maintain her vitamin D levels, not 25D, vitamin D levels.
Right, right. And that's what goes into the breast.
By the way, you can't go to the doctor and say, measure my vitamin D levels, because they don't do that. We just know that it's absorbed really well, it gets into the blood, but it disappears really quickly. So the only way that you can be sure that you have adequate amounts is if you take that amount every day.
Got it. Number 7, which form of vitamin D should be consumed for maximum absorption and bioavailability? And just to let you know, we did have a question come in asking about why one of the women in the studies you presented about, the lady who had hypoparathyroidism, was being given D2, and isn't D3 the recommended level? So if you could answer that.
Well, because if you're the only pharmaceutical preparation that exists for the doctor in a clinic is D2, and that's still true today. This woman was under a physician's care for maintenance of calcium. That was a prescription of vitamin D. That particular form comes in 50,000 unit tablets called Drisdol. That's what she was getting. And in fact, if they were treating the same condition today, she'd get the same thing. It's just that we don't have for bureaucratic reasons that go back decades, we don't have a comparable D3 in the pharmacy. It's only D2. And it's because of stupid rules at the FDA.
So regarding which form should be consumed for maximum absorption?
D3.
D3.
Always D3.
Okay, great. I do believe biotech has a 50,000 IU. I don't know if it's in the pharmacies.
But unless you got all multiple sclerosis and you're trying treatments, nobody needs to take 50,000 units a day.
Question number 8. Are there differences? Oh, we already did at 8. I'm so sorry about that. Question 9. What are the vitamin D recommendations for infants who are not breastfeeding?
The current recommendation of 400 units per day seems to work pretty good. I mean, in our, we did that as our standard of care in our breastfeeding. The infants got 400 units directly, and their 25D levels were in the mid-40s. If the compliance is good, if the mother does it every day. So that seems quite good, that recommendation for a newborn infant.
And you're talking about infants who are on formula instead of breast milk?
No, if an infant is on formula, they don't need to be getting any supplemental vitamin D. They're getting enough in the formula.
Okay, great.
Infant formula from Ross, Mead Johnson, or Wyeth contains plenty of vitamin D, okay? It's only breast milk that's deficient, ironically enough. The formula manufacturers got this down. They have to have, actually, it's closer in those infant formulas, closer to 600 units by overages. You do not need to give vitamin D supplements to a bottle-feeding infant, ironically enough.
Okay. Question 10. Are high-dose vitamin D injections safe for breastfeeding mothers?
No, never do that. No,
okay.
don't do injections of vitamin D under any conditions. I don't care what it is. In fact, in this country, I don't even think we have them anymore. They used to have them. To my knowledge, there's none of them on the market.
Okay, thank you for clearing that up. Question 11, what are the best sources of vitamin D for my 6-month-old baby boy?
The drops, until they start taking solid food and can chew, and then now they have these vitamin Ds and gummy bears that the kids like, but I don't think a 6-month-old is going to be up for that, so it would still be drops.
Right. And 12, I believe you did address, would high supplementation of 10,000 IU a day be harmful for the baby or mother?
No, I don't believe it would be. I mean, on a 10,000 IU per day dose to a mother, she's going to supply about 800 IUs per liter to her infant. So the infant's 25D levels may be a bit higher than what we looked at, but certainly not going to be harmful.
And you keep saying vitamin D levels would be a certain amount per liter for the baby. How many liters on average do babies consume a day?
A normal infant would have a liter intake. That's what the recommendation is based on. So that's the formula manufacturers. They're supplemented on an average volume intake of an infant to get 400 units per day, and that's usually on a liter basis.
Okay. Question number 13, do the recommendations during breastfeeding also change according to body weight of the mother, as well as for the infant?
Not really. I mean, it could. Really, women who are really obese have a real problem. So if you have a huge BMI, you may well have to have a higher intake of vitamin D to get your blood levels higher and into the milk. I can't really answer that question. Actually, that's a research question that should be looked at, but it's just nearly impossible to do that.
Okay. And then question number 14. What serum level is recommended for infants? Is it the same as adults? And I know you kept referencing during your presentation the 20 nanograms per milliliter.
Well, that's minimum. That was our cutoff point. Shouldn't be lower than that, and that was based on Institute of Medicine recommendations. I don't like that. I mean, that's too low as far as I'm concerned, but that's what we used in the study. And again, when we were on our treatment groups, we were in the 40s. So that's what I would look for. It's the same thing for, I don't distinguish between circulating levels in adults and children or infants. To me, they should all be the same.
And that would be between 40 and 60?
Yeah.
Nanograms per milliliter, and that's, what is it, 100 to 150 nanomoles per liter?
Yeah.
Okay, great. Question number 15, how often should you check levels?
I wouldn't. If a woman was doing this, I wouldn't, and taking this, you don't need to bother to check the levels.
And that's for breastfeeding because what you're ingesting?
Yes. I mean, if you know that you have a good supplement and you're ingesting, again, you're checking 25D, and that would be in the infant. But I don't. If you have a good supplement, and you know it's a good one, and you're taking it every day, you probably don't really need to be checked.
Okay. Before we move on to the next section, I did have another question come in about overdosing. What does overdosing look like? How would I know if I or my child was getting too much?
I don't know. I've never seen it. You get hypercalcemia, and you get high urine calciums, but the scary thing is hypercalcemia. And I've actually never seen a case due to vitamin D toxicity. So I know Dr. Veith is, they've seen some in patients taking millions of units a day. I just haven't seen it. I mean, I've seen studies where they give multiple sclerosis patients 40 or 50,000 units per day, and those people don't exhibit toxicity symptoms. I've seen other cases where women were taking, one woman mistakenly was taking 50,000 units a day for 40 years, and the physician stumbled on it because this woman's earlier physician had died, and he looked at her meds, and she had these meds. He couldn't figure out why she was on it. It had been prescribed from her. She'd been on it for years and never exhibited. So the amount of vitamin D intake to get into toxicity is huge. It would have to be in excess of 40,000 units per day, but I don't know where it would be. Nobody, unless you have some pathology, needs to be taken anywhere near that amount. But the ranges are huge for toxicity. Been way overblown.
Okay, thank you for addressing that. On to our next section. Question 13, is there increased compliance with supplementation when only the mother takes vitamin D supplements compared to mother and infant?
I think that's true, because the mother can take it more easily, and again, I've even known women physicians who were trying to give vitamin D to their infants and got fed up with it because the infant didn't like it, spit it out, fought them about it, and finally they just give it up. So it's much easier, as far as I'm concerned, if the mother can take it, then there's no consternation fighting with your child.
Right, right. Question 14, and this is an interesting one. Are there additional benefits for the mom supplementing herself with vitamin D while breastfeeding, such as decreased incidence of breastfeeding complications, mastitis, thrush, painful breastfeeding, etc.? Have you noticed an easier breastfeeding relationship for the mothers who are getting plentiful vitamin D themselves?
We haven't really looked at that, but I would suspect it might be true because those levels of, levels of vitamin D protect you against infection agents. So that's probably a fair bet, but I don't have hard data to back that up.
So no research yet to date on that.
It would be. Our data from this suggests that the mother skeleton is more intact with these higher levels of intake. There is no harm in potentially several good points about it.
Okay, thank you. Question 15. Can breastfeeding failure be prevented with vitamin D3 supplementation? Why or why not? So a little similar to what you just said.
I don't know that. You'd have to ask a lactation specialist. That I don't know that would have anything to do with breastfeeding failure. I don't think they're connected.
Okay. Question 16. Any research about supplementation of breastfeeding mothers beyond the first 6 months? When and for how long will the baby need supplements?
No, we haven't looked beyond 6 months, but you look at what the adequate intake would be. 800 units through the first year, or those levels through the first year of life, and as the child gets older and gets bigger, they're going to need more vitamin D. I know some women breastfeed their kids for 2 years. Although if it's sole breastfeeding or they're getting other nutrients, the real problem comes for children after they go off either adequate breast milk or formula, because once that happens, then their vitamin D intakes hit the floor, and they don't have a source. They don't take as much dairy products. They may drink skim milk. There's which may have its own issues with vitamin D supplementation. But once a child goes beyond infant formula or nursing from a mother who has adequate vitamin D intake, then you really need to be on top of it and get that child to take supplemental vitamin D, whether it be drops or gummy bears or whatever you're going to give them, because that turns into a real problem. They're adequately nourished until that point in time, and when they go on solid foods which have no vitamin D in it to speak of, then their vitamin D status would decline, unless nobody goes outside much or they put on sunscreen, so that's not really an answer to it.
Right. Okay, thank you. 17. Do you know, how does storing breast milk, refrigerating, or freezing for future use? Okay, great. And 18, do you know if there is a higher vitamin D content in the fore milk or the hind milk?
A long time ago we looked at that. It's quite not anything we could track down.
Okay. Question 15, how important is adequate vitamin D3 in newborn brain development?
You know, there's been no randomized controlled trials, but I've seen a couple of trials. One of them came out of Spain this past year. It was a observational study and it was done in Barcelona, where there were some really good vitamin D levels in some of these pregnant women, and they looked at them in relation to motor development and cognitive development. And let's just say that if I looked at that graph, and I was a mother, I would be really concerned about not having enough vitamin D in my blood in the brain development of my child in utero.
Okay, so sounds promising for vitamin D there. How about smoking mothers? Should they be taking more vitamin D?
Shouldn't smoke. uh, probably not. Maybe, I mean, smoking may retard. Somebody here is looking at smoking in relation to nasal polyps and things like that. And what it seems to be what happens is that there's components in smoke that alter the activation pathways in some of the tissues and mess up the metabolism of vitamin D. But so that's a possibility.
Okay, great. Well, it looks like that was our last question. Again, if you haven't already visited the Grassroots Health website, I would really encourage you to join the D Action program, and in joining, you'll become a sponsor of our weekly Grassroots Health webinars. And a recording of this webinar and the question and answers will be posted on our website at grassrootshealth.net/videos, so under the videos tab. And I want to thank you again, Dr. Hollis, as well as our audience, for your time this morning. Please remember to tune in next week for our special webinar at the Linus Pauling Institute's Diet and Optimum Health Conference. And thank you so much again, Dr. Hollis. It was a pleasure having you.
You're welcome. Thank you.
Have a great day.